Hey guys, Mike with FlightBridgeED. I've been an EMS training officer since 2008, and I don't know how many times I've had to deliver the bad news to someone about an expired certification. That means no work. That's where Piace comes in to save the day. Never be caught off guard again with an expired cert. Go to the App Store for your device and search for Piace, P-I-A-C-E-T, the one-stop application to manage and share all of your certifications. You know you don't want to be that guy or gal, and don't rely on your agency to tell you about your certifications. Go to Piace to manage your own certs and have some peace of mind. Download Piace today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey guys, welcome back to the FlightBridgeED Podcast, Foam Frat Attack with Tyler Christofoli and Brian Winchell doing part 2 of the silent killers in pediatric ventilation. Now, we're going to talk about the Hamilton T1 for this episode because it is just such a specialized ventilator. So special. And we were just talking about our ventilator resume, if you will. It sounds like we both started off with the AutoVent, moved to the Eagle Impact ventilator, and then I went to the Envy, which is a CareFusion ventilator, and he went to the LTV 1200, and then we both graduated to the Hamilton T1. That's the end of
final promotion.
That's the final promotion. We're going to talk about pediatric ventilation, and I'll be honest, Brian's got way more experience than I do with this. Before I started working at LifeLink 3, I had zero experience ventilating children, unless it was with a BVM. We had a pediatric specialty team that would come down and pick up all the patients in our area. So if you had anybody, I'm talking even kids that were, past puberty, they would still consider that a pediatric specialty transport, and they would come and retrieve them and bring them out. And so I had zip when it came to pediatric ventilation experience. I bought a book when I started working at LifeLink on pediatric ventilation, and I started reading it. And I don't know, what I found out was that it's really not that different than adults. I just pretend they're like really sick ARDS patients, and I'm dealing with like really small tidal volumes. And Brian, if you could sum up pediatric ventilation in one word, what would it be?
Calm down. I know that's 2 words, but I think, whenever you think about walking in on a pediatric vent case, starting with the human factors is absolutely the place to start. Because I'm the same as you. I started from a background of mostly adult pre-hospital and then learned on the job, just like you did. Our program's a little bit unique. We do a transport volume about 25% peds and neonates. And we've learned a lot over the years by, having really sick patients and then messing it up and figuring out what we can do better. And getting the Hamilton ventilator was largely driven by the fact that we had such a high peds volume. But at the end of the day, when you come down to it, thinking about how you handle a ventilator patient that's a pediatric, so many of the principles still apply that we learn about adult ventilation. And really, when you start doing critical care transport, learning mechanical ventilation is probably one of the biggest things that you have to learn that you didn't have in your toolbox before you came. Do you think that's true?
Yeah, absolutely. I 100% agree with that. And I think it's interesting because, you and I, there's no hiding it. We're, ventilator nerds. There's a bunch of us out there, and we can sit here and we can debate semantics, pressure versus volume, this mode, this IDE ratio. But when you actually get on a transport, your brain goes into like a operational mode. Like, all right, I need to troubleshoot alarms. I need to troubleshoot the patient. I need to troubleshoot the staff. And a lot of those semantics and those details turn into, what do I need to know right now? And that's kind of how I want to like preface and frame this part 2, is what do I need to know right now to possibly benefit this patient, not let them get any worse, and get them from A to B as safe as possible. And that's what we're going to hit on. And I think that the main, the umbrella for all of this is really going to focus on just paying attention to dead space. And so when we talk about the Hamilton T1 and we're going out on a pediatric transport, usually we get the weight. We're trying to decide whether we want to use like the adult circuit or the neonate circuit. So we got two different circuits. Brian, why don't you talk about those two circuits and how they differ?
Yeah, so the two circuits have quite a bit of overlap. There's a neonatal circuit, and then there is an adult pediatric circuit. And so the neonatal circuit really covers the age range up to a weight limit of about 34 kilograms. And then the adult pediatric circuit covers down to about 3 kilograms. So there's sort of a 3 to 35 kilogram overlap. As a rule of thumb, about 10 kilograms and down works much better with the neonatal circuit, and 11 kilos and up works better with the adult PD circuit. If you have a patient that you know is going to have low tidal volumes and you're going to be fighting dead space and they're, say, 10, 11, 12, 15 kilos, air towards the smaller side just to eliminate as much of that dead space as possible if you're going to be running with lower tidal volumes with a lung protective strategy or something. But in general, rule of thumb, 10 kilos and down, neonate circuit, 11 and up, adult PD circuit.
Yeah, that area of overlap was a little bit confusing to me when I first started here, because I'm like, all right, well, if I go in with the adult circuit on, I think my first kid I ventilated was 12 kilos. And I'm like, oh man, like that's all right. So that's 2 above where I would use the neonate circuit. But if I go in there with an adult circuit and I put it on and I start noticing that I'm like getting, I'm retaining some CO2, they're rebreathing it. Then I got to take them off and bag them, switch circuits. And so I was like, oh man, I don't know which one to go with. And I was talking to you, and there's some other points to do with the circuit other than just dead space. And we were talking about the weight of the flow sensor. And honestly, so I stuck with the adult circuit because it was 12 kilos. The tidal volume was higher, I don't say higher, but the kid had healthy lungs. And I went with the adult circuit, and I found myself having to hold up that circuit because I kept kind of bending that ET tube over. And they were using a Thomas tube tamer, Thomas tube holder. I always want to say
Thomas tube kinkers.
I always want to call it Thomas the tube holder because of Thomas the train. And I sound like a real idiot when I say it. But yeah, it kept kind of folding over that ET tube.
Yep. Mm-hmm.
And I was like, oh man, like I probably should have put the pediatric or the neonate circuit on. And so that's something else to consider in the realm. I mean, the kid ventilated fine, but when you start thinking about how could I have made this better, that was definitely a point that we reflected on. I thought, oh, that would possibly be a better idea.
Yeah, that's a good point. If you look at the latest iteration of the flow sensor and the Y on the neonatal circuits, Hamilton has put a 90-degree elbow built into the Y. And so it's a lot less plastic hanging off the tube.
Yeah, that's great. We decide we're going to use the adult or the neonate. And honestly, since you can go up to, what is the tidal volume? Like 300 is the max on the neonate. You could probably ventilate some adults with that. So I would say I would err on the caution of going to the neonate mode. Now, when we look at the neonate circuit, it's rigid. And my thought process, and what I had always been formally taught, was that there is a certain amount of volume loss in tubing compliance. And some books will say 2 mLs per centimeter of water pressure, of your peak pressure. Some will say 1 ml. And so this was something that I'm like, all right, well, usually when I teach dead space, I teach everything distal to the flow sensor contributes to dead space. And I was working with one of our flight nurses. His name's Keith Velasky, super smart guy. And he said, all right, so if everything distal to the flow sensor, then why are we teaching people that you lose volume with tubing compliance? And I'm like, dude, that's a really good point. It doesn't make sense to me. It's just like one of those laws, like, they always say you're not allowed to drive with your lights on inside the car because it's illegal, but like nobody can find that rule anywhere. And so I'm like, all right, this must be something. And so I reached out to Joe Hilton. I hope I'm pronouncing that right. One of the reps for Hamilton. And he said that when you are calibrating that circuit, it accounts for that. So you don't even have to worry about that. It's so small that it's not a factor. Has that been kind of your same experience?
Yeah, Joe's a super smart guy and a practicing RT and a great resource for people to go to. And yeah, part of the magic of the Hamilton is their flow sensor design. So whether you're using the neonatal circuit or the adult pediatric circuit, one of the things you have to do is calibrate the flow sensor when you put it on or before use. And so there's inside that little blue flow sensor that sits directly between the Y and the patient, it's physically measuring tidal volume going through there, as opposed to other products that don't have that flow sensor, don't have a way to physically measure volume. They can measure pressure and then estimate volume based on the pressure returns. But that flow sensor is incredibly accurate. So just really when you're talking about mechanical dead space, you're talking, to the best of my knowledge, from the Y past the flow sensor to the patient is the dead space that we're really thinking about. So the flow sensor contributes to dead space slightly. The neonatal flow sensor is about a cc of dead space. The adult pediatric one is a little bit more than that. I haven't measured it recently. It's like 10 cc's. But the flow sensor does an incredible job of determining that, so that you don't have to worry about part of your equation doesn't even have anything to do with tubing compliance.
All right. And I think that's a really good point. So we can kind of just squash that. So don't really worry about tubing compliance. And you couple that
on the
with
Hamilton.
On the Hamilton T1. Yeah.
Correct.
And you couple that with the decelerating flow pattern and the T1 pressure. And I just really think, like you said, it's just not an issue at all. So now my next point that I was like, I don't know, on my first pediatric ventilator call was it's cold up here in Wisconsin. I know you guys don't really deal with that down in Texas much. And we were doing a flight with this kid, this 12 kilo kid. And my thought process was like, we're going to be going in and out. I want to try to keep that airway warm, right? I don't want them to dry out. And so I was debating whether I should keep the HME on or take it off. And if you ask, like, a bunch of people in a room, everyone gives you their own opinion on what they think you should do. And Eric quoted a study that we'll include in the show notes of this about the HMEs and how they actually, without having one on for a certain period of time, it can have some effects on the airway. And so I was like, I'm going to keep it on because, this kid, I want to try to keep him warm. And the tubing, how the tube, you used to live up here in Wisconsin. Mm-hmm. You know how that circuit gets cold. It's freezing. And you want to try to keep some of that heat and moisture in. So what's your thought on the HME, Brian?
This is the classic debate. If you polled the room and then you took all the experienced people, they would all say throw it in the garbage as soon as you show up, because it down the road presents problems in flight. I think the prudent approach is to say, hey, there's an advantage to the HME. Whenever possible, we can use it. But if you look at your HME, I think there's some things you got to figure out as to what HME you're carrying. The dead space contained in that HME is really important. A simple way for you to measure it is to occlude one side and then just take, say, a 60 cc syringe full of water and fill it all the way up and see how many mLs of water it takes. And that's roughly the amount of dead space it's adding. And boy, when you start stacking things together, you can end up with a lot of dead space really quick. So if you're sub 10 kilos, it's going to be really hard to find an HME that has a tiny amount of dead space. And we actually, for a while, carried one that was a tiny neonatal HME. But ironically, we found it doesn't even really work with the way that the flow sensor works and the neonatal and tidal CO2 works, because it was so compact, it wouldn't allow them to fit together. And so really, you're looking at something with about 10 cc's of dead space minimum. And I think it's going to be if you can use it, that's great. But if it's causing problems, and when I say problems, think through, you've got a medium in there that's basically cardboard that you saturate with water. The more that it's saturated, the more that it increases resistance. So you can end up with sort of a high resistance type patient that has a flow waveform that's not returning to baseline or high peak pressures. And that's time to get rid of it. Or if you end up with a lot of dead space and CO2 rebreathing that you can notice, that's another time to get rid of it. So it's a great tool, but don't be afraid to get rid of it if you have problems. And then make sure you're putting yours on and that you've picked out the appropriate one for transport. Because if you look at the standard ones in the hospital, you're talking closer to 20 or 30 cc's of dead space.
Let's go back to what you said if you're noticing problems, because you kind of briefly touched on it, but I think that is so important. With your best monitoring device, when you are trying to figure out if you need to reduce dead space, is your end tidal CO2 waveform. Is that correct? Would you feel the same way?
Yeah, there's two things in the waveform you really want to look at. And the first and most obvious is the baseline. So the portion of the end tidal CO2 waveform that should be the baseline, or the isoelectric line, if you will, where during inhalation should all the way be down at 0. We've got several cases, and we'll put a blog post up on Foam Frat, of cases where that baseline elevates even up to 30 and the CO2 waveform then goes up to 60 beyond there. So it's not returning to baseline. And that's a sign of CO2 going in to the patient during inhalation, right? And so that's CO2 that's found in dead space getting pushed back in. The not quite as bad situation, but can still cause problems is if you have some CO2 getting pushed in. And what this looks like is a little bit of a tail or a triangle that cuts into the baseline on the left side of it. And so that's a little bit of CO2 left in the HME or in the circuit getting pushed into the patient, and then it goes down to baseline, and then you get a normal breath. So we call it tailing, or it looks like a little triangle impinging on the baseline. Both of those are signs that you've got too much dead space, and it's really important to be watching for this. And what the clinicians will usually complain of is they have hypercapnia and they have trouble reducing it, even if they're increasing rate and tidal volume, that they can't ditch this. And if you pull out the HME or you pull out all this dead space or inline suction or flex tubing in elbows, usually you can resolve it really quick.
Now, I haven't seen the tailing until you shared with me those images the other day, but mine has been a elevation of the baseline. When they're taking that breath in, that should be dropping, and you should have no CO2 there. And if you see
you should not be inhaling CO2 as a rule.
That's the point of this podcast.
Right. Don't inhale CO2.
I think of it when I explain dead space, like when I'm teaching mechanical ventilation, I think of like the snorkel, because if you had a snorkel, they have to make it, a certain height. Otherwise, you're going to rebreathe part of your own tidal volume. I mean, you still are going to rebreathe some of your own tidal volume, but you're still drawing in some more atmospheric air. Now, If you were to extend that snorkel, you would eventually just be rebreathing all of that CO2 in there. And so when you think of bias flow, and we did a podcast, it was like one of the first podcasts I ever did on bias flow. That is circulating throughout the circuit, clearing that dead space. So you don't have to like breathe all the way back to the exhalation valve and suck all that in. Or the Eagle vent had like an expiration valve, like real close to where the tube would connect, and you could exhale through there. Once you get past the flow sensor, you're circulating it. That's where the snorkel hits the air. But everything after that, everything distal going towards the patient of the flow sensor is all contributing to that dead space. And so we'll put those pictures in the show notes. And Brian's got a really good blog he's going to put up on Foam Frat, just showing those baselines, because that's something so important to pay attention to. And if you are not keeping the end tidal CO2 on pediatric transfers, you'll never see this. And what you're going to do is, if you're trying to, I don't even know how you would know to increase the rate or what you would predicate or what you would base that off of. But if you have the end tidal CO2 on and you're like, oh, all right, normally when that happens on an adult, let's just increase the frequency. We'll turn up the respiratory rate. Why is that just going to make it worse, Brian?
Well, that's a really interesting thought, is respiratory rate in kids is not necessarily benign. And we think, an infant, normal respiratory rate, 30 to 60. You don't want to be living at 60. You really need to be, we teach 40 and down, because the more respiratory rate you have, the more dead space ventilation you have. So if you have a tidal volume of, let's just say, 80 milliliters, and of that, you've got 15 milliliters of dead space. The more you increase respiratory rate, the more you increase that amount of dead space ventilation. So the ratio of dead space to alveolar ventilation didn't change when you increase respiratory rate. But if you increase the pressure control or increase the tidal volume, you're going to get more alveolar ventilation, and the dead space ventilation remains constant.
And when it comes to alveolar ventilation, you know that to oxygenate adequately, you really don't need a ton of ventilation on the oxygenation side. There's some charts that I have that show that you really only need at 50% FiO2, like 500 mLs a minute of alveolar ventilation. But when you look at the ventilation side, that's really what we're worried about. So my point in saying this is that you can't use your pulse ox as, well, the ventilator's working fine because my pulse ox is 100%, because that is not true. That's going to take a little bit longer to start to change. Now, if you're rebreathing, a ton, yeah, you will see that drop. But if you see the pulse ox dropping, you're kind of behind the 8 ball on that. All right, so let's move on to like our initial settings for a kid. So I typically use like, I don't know, 6 to 8 cc's per kilo, but the Hamilton calculates that in when you put in their height.
Yeah, all of the ventilators have configuration settings, so your program can set up centimeters or inches. We use inches because we're in America. We also set it up so that it starts at 6 per kilo. There's a lot of debate on cc's per kilo, and of course, PEDS has very little evidence or published evidence. If you look, I think it was in 2016, there was a consensus document put out on Pediatric ARDS, and their consensus was tidal volumes between 5 and 8 cc's per kilo. But really, the experts sort of are all over, like they expand this a little bit. There's some that think that, yes, there are times where we need to be down in the 4 per kilo. On the other hand, kids with healthy lungs probably don't have a problem up higher, close to 10. If you look at, the ARMA trial, which is what everybody's basing it on, we're comparing 6 versus 12, but, is 6 versus 10 going to be a detriment? There's not a lot of pediatric literature on that. So in general, we stick between 5 and 8. And watch really your plateau pressures or your peak airway pressures and trying to maintain them about 28 to 30 is more the concern that you're going to watch.
Now, I think it's interesting because, usually we say we're going to ventilate at 6 cc's per kilo or, 8 cc's per kilo, and then we'll keep them at that. And I was reading a pediatric ventilation book about the type 1 and type 2 pneumocytes. And in order to have surfactant like get released endogenously, you have to activate the type 2 pneumocytes. And that only happens when you start to expand them. So I think that makes sense for, as like us, like physiologically, once in a while we'll let out a sigh. And I think if you're having a hard time ventilating a kid, it might be worth trying to do a sigh maneuver on them and see if they have surfactant. This is a kid that's, maybe old enough to have that, or they're not like a neonate that needs artificial. But that might be something worth trying, is just doing a little bit higher of a breath, a sigh maneuver, and then seeing if that works. And there's a button on the Hamilton to actually activate that sigh.
Yeah, and I think we're really in a state of the science where it's continuing to evolve. If you look at the safety parameters that we're using, plateau pressures, peak airway pressures, everything's a surrogate for how much stretch you're actually putting on the lung parenchyma. And so we're all trying to figure out what's the deal, what's the right number. And not everybody can do, transesophageal pressures. So is it dangerous to have higher respiratory rates than we need? Is that causing more stretch? Or, there's a lot of questions. So I think right now staying in that target PIP of 30 or less, keeping your tidal volumes generally between 5 and 8, but then not being afraid to go up to 10 if needed or down to 4 if needed, I think gives you the flexibility to sort of adapt the modality to the patient as the science continues to evolve.
If you're ventilating at a lower tidal volume and you're slowly increasing your respiratory rate to try to make up for that, do you have like a cap that you're looking at? What are you basing your rate off of?
Man, we don't have a hard stop. Honestly, it is nice when you set in the patient's weight or height. It gives you a suggested starting respiratory rate, which is a really good starting place. If you look at the tables, it's a good place to start. We don't have a hard stop on it. I think in general, the no faster than 40 is a pretty good place to be if you're looking at patients that are 2 and 3 kilos and larger, like what we do. If you're getting into the smaller than 2 kilos, you're in a little bit of a different world where frequency is looked upon differently. Another thing when you think about rate, I think that plays into this is when you think about obstructive patients and how low do you go? That was always a question that I had too, right? So you think of an adult patient that is severe asthma, we start with rates that are really low, like 8 breaths a minute. Well, what would you do with a 8-year-old that has a severe asthma attack? And I think what you want to do here is look at your flow waveform. I can't emphasize understanding that flow waveform enough and say, when is that thing getting back to baseline? The flow waveform above the line is inhalation, below the line is exhalation, and that exhalation needs to all come out. So it needs to come back to baseline. And if it's not coming back to baseline, then we need to slow the rate down or possibly shorten the eye time, although generally we've found pretty good success with a little bit longer eye times and the slower respiratory rates so that you give enough time for that breath to get in past that resistance as well. What we found with kids and asthmatic kids And Joe Hilton can really speak to this as a guy that transports a lot of really sick asthmatic patients. Sometimes there's baseline left on that flow waveform where that exhalation has come all the way back to baseline and it's just hanging out waiting for that next breath. And if you have a hypercapnic patient, that's all free room for you to buy up. So that means increase that respiratory rate. You want that flow waveform returning to baseline and the next breath starting immediately after that. That means you're safe, you're not air trapping, but you've optimized the respiratory rate so that you're getting as much minute ventilation as you can out of that patient safely.
That's such a good point. And if you go on the Hamilton website, I should just go on Google, type in like Hamilton T1 simulator. They just came out with a new one for the C6, is it, I believe?
Is it?
I think it's the C6. It's the hospital model. And they have a whole simulator on there, and you can learn how to bring up these waveforms. Something interesting that Kyle Dreesy and I did is we would take that simulator and we would make like a sick asthmatic or whatever, not let them see the patients, like hide the patient information and be like, all right, dude, you walk in and here's the ventilator. What are you going to do?
Nice.
And we would sit there and try to and then sometimes we'd do it on 2 laptops and then we'd race ASV to see if it could normalize the settings before we could beat the machine. Yeah. And it is so cool because that's the time to do it, not when you got a patient on it. If you want to bring up those waveforms, you just tap the waveform screen, it'll pop up. And then it'll ask you, do you want, a loop? Do you want a waveform? What do you want? And I think that when I'm monitoring it, I like to have that flow waveform. And then I like to have, sometimes I'll do like a pressure volume loop.
It's really hard, man. That flow waveform is so important, I think, for these patients, especially the obstructive patients, to make sure they're exhaling.
Yeah, and you might see if you had the HME on that, it's not returning to baseline because of that building up that resistance. And you might find you can fix that by just taking that HME off. All right, so when you are ventilating a kid, like if we're intubating them, we're probably using a cuff tube. But we're not always the one putting the tube in. Sometimes we're picking up these kids and they don't have ET tube with a cuff because I think it's still going around that you're not supposed to do that.
It's unfortunate, but yeah, the industry has changed. Everybody, we're using cuff tubes, but
so just write that down, put it in the the lunchroom at the hospital or wherever you are, cuff tubes for everybody, because otherwise you run into these leak issues. What are you doing for that?
So leak is a really interesting thing. It was big enough for us that we put VLeak as a monitored parameter on our home screen. You can get to it in page 2 of the monitoring tab, and you can see VLeak. And you can also sort of estimate it looking at your VTI and VTE and seeing how different they are. VLeak's a little bit more accurate because it's averaging it across, I believe, about 5 breaths and giving you a percentage difference. But between pediatric patients and non-invasive patients, we found VLeak such an important parameter that we put it right on the home screen so we can all see it. And so whether you have a non-invasive patient and you see that leak climbing through 20%, it's time to tighten up the mask, adjust it, do some anxiolysis. With a pediatric patient, kind of the same idea. North of 10%, we start getting a little bit uncomfortable and looking at it. It totally depends on the patient. If you're requiring high levels of PEEP to ventilate this patient, if you need a good mean airway pressure, then you really need a minimal leak. If it's healthy lungs, it's a trauma patient, something like that, it's not as critical. And if you're ventilating satisfactorily, and then you're probably fine. But so we don't have a hard cutoff. 10 to 20% and higher, you start wondering if you need to start looking at changing it out. We do carry 6 French bougies as well as 10 and 14 French for doing tube exchanges. It's never fun to do it on a hypoxic patient that needs a lot of mean airway pressure, but at least the 6 French bougie helps it go a little bit quicker. Yeah,
that would be an interesting scenario, trying to say, yeah, you know what, I know your ventilator is working fine, but when I put them on mine, I'm getting a low pressure alarm, or I got a huge leak. Or have you ever run into a ventilator circuit failure because it's noticing that it's losing air too fast?
We haven't gotten that far. A lot of times you'll get a low PEEP alarm too. There are definitely times where you've got to switch it out just because you're not providing the PEEP and you're getting these low pressures right off the bat.
All right. So on the topic of equipment, you can't really just use like an adult end-tidal CO2, and if you can't find your neonate one, you got to have the actual stuff because of what we talked about with the dead space. But the other thing that we were talking about was the tube holder, because the Thomas the tube holder The Thomas the tube holder, when you clamp that down, I mean, on a 7.0, 7.5, whatever, 8.0 tube, it's really not an issue. But when you start dealing with these tiny little tubes, you can completely occlude the tube, and you could be thinking that you got some like asthmatic patient, and all it is that you just tighten that clamp too hard.
Sure. Or it kinks over across the top of it, especially on those smaller tubes. Yeah. So I think proper tube securement is really important. We've gone round and round on the right ones to use. We've settled on the NeoFit and the ComFit devices. They're both made by Cooper Surgical. I have zero financial interest in the company, but they work really well. They still allow you to get OG and NG tubes past it. It prevents that tube kinking. I think another thing to think about just when you're thinking about equipment size is, are you carrying the right size of soft suction to suction out really small ET tubes? If you're transporting somebody with a 3.0 or a 3.5, you really need a 6 French soft suction. So we carry 6, 10, 14 of pretty much everything, which covers your age range. So bougie, stylets, soft suction, OG and NG tubes, we have 6, 10, and 14 of everything. And 6 pretty much covers your infants, 10 covers your PDs, and 14 covers your adults.
We have the same thing.
Yeah. And I think sometimes that gets omitted, and you're like, oh, wow, I can't fit this suction down there. Same with the end-tidal CO2. There's a specific neonatal end-tidal CO2 for mainstream and side stream. I think most of the industry is using side stream. If you're using Zoll monitors and or physio monitors, largely those are side stream. But if you're a less than a 5.0 tube, you should be using that neonatal end-tidal CO2. And then another thing I think that we forgot about for a while is, so PD and neonatal decompression needles, right? You always think, oh, I'll grab a 18 gauge angiocath, but a lot of these safety angiocaths are not suitable for doing a decompression. And I mean, it's not like you want that to be part of your mechanical ventilation CPG. We'd like to stay out of pneumothoraces, but it's, the dope mnemonic is part of life, and trauma patients occur as well. And so what are you going to decompress them with? And so finding the right size, like an 18 gauge 1.75, that you can attach to a syringe to aspirate, as you're doing a decompression, is really important. And preferably one that's like an FEP polymer that doesn't collapse when it gets warmed up to body temps, like normal angiocaths do. So lots of things to think about. How do you secure them? Can you secure them, or do we just rely on a PD mate, which really doesn't work super well in less than 10 kilos? Do we have a way to keep them warm, monitor temperature? Lots of things to think about to make sure that you kind of get things lined up. And there are things that line people can help influence decisions in their program. So if you're working in a program, you're like, wow, we're transporting a lot of kids. These are things you want to make sure that you have lined out, and you can have a voice to take it up the chain and say, hey, we're transporting a lot of kids, and a lot of asthmatic kids or kids with bronchiolitis and RSV this winter. We're really struggling to nebulize with them. That was something we had. And so we moved to the Aerogen nebulizer, which doesn't use a gas, use electricity and a vibrating mesh to dump it in. And so you don't end up with messing up your flow waveforms and everything while you're nebulizing. Those are things you can run up the chain and say, hey, here's some research, and here's how it can benefit our pediatric populations.
Yeah, well, so that was going to be my next question is, you got to do a neb on a kid. And when you're using the Hamilton, I have always put the nebulizer on the side of the flow sensor going towards the vent, so not after the flow sensor. And that was the way that I was kind of told to do it, so that way it wouldn't change volumes, it wouldn't contribute to dead space, especially in a kid. Now, is that the same with the Aerogen?
So when you think about the Hamilton circuits, there's two types of circuits, right? There's coaxial and collinear. And the difference would be like the neonate circuit is collinear, 2 tubes next to each other. Our adult PD circuit is coaxial. Is that how yours is? 1 tube inside the other?
Correct, yeah.
Yeah, so it's really hard to put it in the inspiratory limb of that circuit. So what we do this with our jet nebulizers, the gaseous ones, and we do it with the Aerogens as well, is we actually put the nebulizer directly on, the T is on the Hamilton in the inhalation port coming off the side of the Hamilton. And then that connects into the tubing and goes through there. And then the exhalation port goes out. And then we put a little flex tubing on there so that it fits. And the reason for this is that bias flow that Tyler mentioned slowly fills that inhalation circuit with nebulized medication during exhalation, and then you get a good bolus of that going in during inhalation, and then during exhalation, that gas isn't getting nebulized back down the exhalation port. It just sits there and sort of accumulates in the inhalation side. So that's why we put it directly on the vent so that we can isolate the inhalation leg.
With the NV ventilator, we did the same thing, just because otherwise my bias flow is washing out all the drug before they even got to the point to inhaling it. And
Right.
so it made sense to put it down on that inspiratory limb. Now, when it comes to modes, all of them are pressure modes, but we have like volume targeted pressure modes. What do you think is the best mode to start a kid off in?
So this is something that's interesting. We've kind of been learning it as we've learned the Hamilton across the last 3 or 4 years that we've had them since transitioning from the Revels. And initially we all lived in the PRVC mode, which is called CMV+. And I think the way that we've sort of fallen now, and this has been the collective, wisdom of our experienced people here, is if you have a patient that has healthy lungs, and let's say it's a kid that's 8 years old, got kicked in the head by a horse, and you just intubated them for airway protection, and that patient is great on CMV+, because you can set your target tidal volume, you can sort of forget it, you can do the rest of the things you need to do in transport, your fast exam, et cetera. You can kind of check down at the end tidal CO2, make sure it's where you want it, make a few tweaks, great. If you have somebody with sick lungs, we're starting them in pressure mode, like a PCV+. And this doesn't have anything to do with is one better than the other, because it's all in the Hamilton. It's just how the clinician interprets it and interacts with the dials. And with the Hamilton PRVC, it goes through an algorithm and escalates. And if you have somebody that's going to have sick lungs, starting in a pressure control mode lets you make a change in the very next breath, see how that worked out. And so your reaction time is a lot quicker. So that's what we've moved to, is if they're going to have sick lungs, we just start in PCV+ and use that. If you need sort of a set it and forget it mode, CMV+, or honestly ASV is pretty phenomenal as well. Those are probably your better modes for that situation. The one last thing that I'd throw out there is it's easy to get fooled on oxygen consumption. They've made some good software changes in the last couple of years so that the consumption is much better. But even when you're using the neonatal circuit, there's a 4 liter per minute bias flow. And so still check, if you're going a long distance, checking your oxygen, it makes a ton of sense. We built an app internally for this, and it makes it super simple. Hit the system tab. It comes up. It tells you the liters per minute that the Hamilton's burning. And so it's super easy math, but don't get burned because you think you've got a 3 kilo kid and you're not using that much oxygen. Sometimes they use almost as much as an adult does when you sit there and calculate it all out. So they make it easy for you. Don't let that piece of information slip by you.
And I can't stress enough getting online and playing with that simulator and messing around with it.
Very good.
Trying to recreate some alarms. And that's what I do when I am trying to learn a new piece of equipment, is I get a list of all the possible alarms that you could get. And then I try to like reproduce each alarm. So then I know how to fix them if I see them pop up, because that's really what we're doing, is like troubleshooting the entire call, or trying to stay ahead of that so we don't have to troubleshoot. But that's kind of from an operational standpoint, that's what we're looking at.
And wrapping it back to human factors where we started, honestly, walking into it, the Hamilton makes pediatric ventilation incredibly easy. I find we have way less alarms on kids than you do with adults, because you're not dealing with obesity and compliance issues. Kids are generally fairly compliant. They're pretty healthy lungs, and so the disease processes are simple to figure out. It makes it incredibly easy. And sometimes just walking in with confidence, knowing you've got a great piece of equipment, you've got great training, you've done a bunch of sims or online stuff, and to tell the mom and dad that, like, hey, we transport lots and lots of kids. I tell almost every parent that, and it gives them confidence, and it gives me confidence. It's sort of it helps everybody get on the same page and take some of the stress out of the room. And that's what we should be. Is we should be really good at our jobs and know how to walk in and take a patient and optimize their settings, get rid of dead space, tweak a few things, and make things much better than where we found it.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.